When it comes to diabetes technology and its efficacy during pregnancy, you'd be surprised by how few official trials have been conducted to study this. Until recently, today my guest and I are talking about two studies in regards to just that. The first is a study on the accuracy of continuous glucose monitors, specifically the Dexcom G6 and G7, during pregnancy for those with type 1, 2, or gestational diabetes. The next is known as AiDAPT, a randomized controlled trial examining the efficacy of automated insulin delivery amongst pregnant women with type 1 diabetes. Welcome to Diabetech. I'm Justin. I have type 1 diabetes, and on this show, I talk all things diabetes tech, news, and management with industry leaders, educators, and those thriving with diabetes. Today's guest, Stefani Guerra, comes from across the pond in Edinburgh, Scotland. She is Dexcom's Director of Scientific Affairs and supports all investigator-initiated research in Europe. She has had the privilege of supporting AiDAPT, that automated insulin trial we're covering, and a few larger randomized controlled trials, demonstrating the benefits of technology for people with diabetes. We get into these two studies, their results, why it's taken so long to get here, and the ongoing research in the works. New podcasts release every Monday on all podcast platforms and on YouTube, so be sure to follow wherever you prefer. And if you're watching on YouTube, be sure to give this video a like if you enjoy it, because it helps other people see it. And if you're on podcast platforms and want to review it, go for it. Unless it's a bad review, then just skip it. Keep in mind that anything you hear on this podcast or content on any of my pages is not medical advice. Always consult with your physician before making changes to your healthcare. Now, a quick word from our sponsor. Today's episode is sponsored by T1D Exchange. You can directly make an impact on diabetes healthcare, treatments, and technology by participating in the T1D Exchange registry. It starts with a simple survey about your life with T1D, and it only takes about 15 minutes. After that, you'll have a personal portal with ongoing T1D study and survey opportunities, from research on technology, daily T1D management, and more. Plus, some of these studies even offer compensation. Signing up with the link in the show notes helps support my channel, and it allows me to continue putting out free content. You can sign up at t1dexchange.org/diabetech or click that link in today's show notes. Now for the episode. Steffi, thank you so much for coming on the show today.
Absolutely. Thank you for having me.
Of course. So I was saying just before we started recording that I really don't have much experience in this area of pregnancy. I got the diabetes part down, but the most experience I have recently would be my sister who just had a baby, which was incredible.
Incredible. Yes, it's an incredible time in any case, if it's a healthy pregnancy or a pregnancy complicated by diabetes. So it's a complicated time, metabolically speaking.
Yeah, and what I find so interesting is, these new studies have come out, and that's why we're talking today. And as someone who, I was just diagnosed a couple years ago, and I was, introduced with all this technology that just, for the most part works very well. And I didn't realize that there was a limit on the studies and the information that we had when it comes to diabetes technology and pregnancy. And that's why I'm looking forward to this conversation. First, I want to kind of set the stage. How new is the use of continuous glucose monitors during pregnancy?
It's fairly new. So Dexcom got an approval for use in pregnancy in Europe with the G6, and now in the US with the G7 device. So it's fairly recent, I would say 5-6 years of experience, and a slow adoption, of course, because the evidence base for the use of CGM in pregnancy is a bit thin, or was a bit thin. Now we're catching up with the evidence, of course, but it's picking up, especially out here in Europe. There have been a couple large studies, not done with Dexcom devices. There's the concept trial. That's the first study that looked at the benefits of CGM in pregnancy complicated by type 1 diabetes. So that's a very interesting study that showed improved outcomes, neonatal outcomes, improved HbA1c during pregnancy. So very successful study. And now we're catching up also with the rest of the technology, which is the automated insulin delivery and closed loop for type 1.
So for someone who had type 1 and was routinely using a continuous glucose
Mm-hmm.
monitor and then they became pregnant, did they, let's say this was 6 years ago, did they
Mm-hmm.
just stop using a CGM because it wasn't necessarily going to be accurate, or did they just continue use and hope for the
Well,
best?
technically, the use of the device during pregnancy was off-label for Dexcom
Okay.
up until in Europe up until G6 and in the US up until G7. Now, what people do routinely, it's a different story. Many people were using it off-label. Now, the question you ask is about accuracy, which is an interesting one. The reason why we didn't have an indication for using pregnancy is because our devices were tested for approval. So our pivotal trials were done in people who were not pregnant. And this is quite common. The involvement of pregnant women in research is not as extensive as for people without who are not pregnant, and this is true for all treatment, I would say. And there's things are changing. Up until recently, pregnancy was considered, or pregnant women were considered part of a vulnerable population. Now we tend to think about them as scientifically complex rather than vulnerable. These are ethical distinctions, but care needs to be used when we are, involving pregnant women in a trial, because there are ethical considerations that are, of course, a bit more nuanced than a non-pregnant individual.
Yeah. Why is it so difficult, or why would you say it's taken so long to get this information, these studies on pregnancy?
Well, as I mentioned, pregnant women were considered vulnerable in a sense up until recently. Now things are changing, but the regulations to run a study in women who are pregnant are a bit more stringent, I would say. And there is also a tendency from the IRBs, so those bodies that approve studies from an ethical standpoint, to be a bit more on the conservative side, because there are concerns about, there's fear of harm for the fetus when you're trying a technology that has never been tested before. There's the threat of legal liability if something was to
Mhm.
happen. There's the whole area of how complicated the physiology of a woman who is pregnant actually is. So we're talking about a complex state, metabolically speaking. So we just don't know enough. And there's this fear of harm that makes it easy to be very conservative. And up until recently, there was the presumption of exclusion, let's say. So we would consider pregnant women to be excluded a priori from studies,
Mhm.
whereas now there is we're becoming a bit more open. There are still all the ethical considerations that need to be done, of course, as they would for any other individual involved in a study. But now there's also this understanding that not including certain populations in study may raise other ethical issues. So, for example, they may be undertreated because there is no evidence base for the use of technology. So it's a nuanced, balanced conversation that needs to happen with the IRBs or the ethics committees, as we call them out here on this side of the pond.
Yeah. And were there or are there any factors during pregnancy that can affect CGM levels? Like did CGMs need to
The
get to where they
accuracy.
are today? Yeah, the
So
accuracy.
now we know that CGMs are accurate during pregnancy, so the studies have been run. Now, when we talk about accuracy of CGM, we need to be quite mindful of how a proper study needs to be conducted to make sure that we understand accuracy. And that's why it was a bit tricky to run studies in these populations, because to have a proper, well-designed study for accuracy, you should be spanning the whole glucose range. So you need to make sure that you have enough data in hypoglycemia, in euglycemia, and in hyperglycemia. So what tends to happen is that the study participant comes to the clinic. They have either a delayed bolus or they don't receive their breakfast immediately, so that they're driven to hypo or and hyperglycemia, so that we can understand how sensors behave in different ranges. Now, if you think of doing that with a woman who's pregnant, there is fear of harm in this case, of course, right? Because you're not only affecting mom, but there is also a baby in the womb that is growing. So in this case, we don't span the whole range, but we have sufficient data to still show that our sensors are accurate during pregnancy and they're safe to use for women, and women can take medical decisions. So we're approved for non-adjunctive use during pregnancy. It's running an accuracy study is quite a complex endeavor, and you need to be very mindful of what you're doing to have appropriate data to show accuracy and consistency of accuracy through different days and different ranges and so on.
Yeah. You know, this question just popped in my head. It's not on my list, but if the woman who's pregnant has a hypo or a hyper, does the baby also have that and experience? Like, if there maybe a certain growth, like, are they feeling that?
This is a very tricky question. Are they feeling that? I don't think we know how to test that. Mm-hmm. But of course, you know, you have a system of mom and baby that is in equilibrium. So we know that the baby pulls glucose from mom to grow. We know that there is a state of insulin resistance, especially in the third trimester, that promotes this transfer of glucose to the baby. The placenta generates and secretes hormones. The baby at a certain point will start generating and secreting its own hormones. So it's an equilibrium that is quite tricky to maintain. We know that hyperglycemia can be dangerous for the development of the baby, for example, in several ways. We know that, for example, having a high HbA1c when you enter a pregnancy is associated with a higher risk for congenital abnormalities. So there are reasons why having a tight glucose control for mom is super important, not only for mom, but also for the correct development of the baby. There are complications that can occur both for the baby and mom if there's a state of sustained hyperglycemia during pregnancy.
Okay. And so the Dexcom CGM is approved, the G6 Europe, G7 in the US.
We also have G7 in Europe, meanwhile.
And G7 in Europe also. It's approved for T1, type 1, type 2, and gestational diabetes.
That's correct.
I have a pretty good understanding, I think my listeners, of type 1, type 2, gestational diabetes, though.
What is it?
Still don't. Yeah, I don't have a great understanding of it. Can you explain that to us?
Sure. So if we start from a healthy pregnancy, there are changes in the metabolic state of a mom, even in a healthy pregnancy. There's a state of insulin resistance, as we said earlier, that promotes the transfer of glucose to the baby so that the baby can grow. Now, gestational diabetes is a condition that arises during pregnancy that is associated with hyperglycemia. So some women develop a diabetes condition that lasts during pregnancy. So they have a abnormal insulin resistance, I would say, that can be treated with diet, with exercise, or in some cases with insulin. But this state of diabetes is resolved at birth. So after birth, these women have normal glucose tolerance. Now, if you are diagnosed with gestational diabetes, there is an increased likelihood for you to develop type 2 diabetes in the future, or to have a second pregnancy, for example, where you might be at higher risk for having gestational diabetes again. But basically, the difference is that it's a condition of diabetes that is, it's first observed during pregnancy and generally resolves at birth, with the birth of the baby.
Wow. Okay. Now I want to get into this specific clinical trial that
Sure.
Dexcom was a part of. So at this year's EASD, there was a study that showed that the Dexcom G7 is accurate overall during pregnancy, during all sensor wear days and glucose ranges for those three different types of diabetes. Can you
Yes.
tell us more about this study and kind of what the parameters were?
Well, that's an accuracy study. So generally, when we do
Okay.
accuracy studies, we measure the so-called MARD, which is a mean average relative difference, which is a way to understand how distant my CGM values are from a lab reference. Generally speaking, the lower the MARD, the better. It means that the difference between the lab and the CGM is not that big. But that is just one metric. When we talk about accuracy studies, we also measure other parameters. There's percentage 20/20, percentage 15/15. We have the accuracy in different ranges. So in euglycemia and hyperglycemia. So we just isolate those pairs of lab reference and CGM that are in the normal range, in hyper, and we see how different we are in these ranges. And these combination of metrics gives us an understanding of how sensors behave throughout the ranges and through the days and so on. So the MARD gives you a simple value to give you a ballpark of where the accuracy is. So the lower the MARD, generally the better. But because of some of the way the MARD is mathematically defined, and I'm not going to bore anyone with maths today, if you have fewer values in the hypoglycemic range, you can reduce your MARD. So the MARD is not the whole story. To have the whole story, you need to understand the accuracy in different ranges. So there's different metrics, as we said, the percentage 20/20, the MAD in hypoglycemia. So what we do when we try to understand if a sensor is accurate is we look at several parameters that can give us the whole story. Does that
Okay.
clarify a bit more?
Yeah. Yeah. How long did it take to perform all of that?
Oh, I need to look back there. Generally, they're quite speedy once you start. It's a bit
Okay.
more difficult to recruit pregnant women, of
Yeah.
course, in a study. But the accuracy study per se, it's usually one sensor wear. So the patient comes to the clinic in one of three sessions. So it could be on day 1, on day 3, on day 7, or day 10,
Okay.
because we want to understand how sensors behave in different in different days. So it's not like a 6-month study for the single participant.
Okay. And was this accuracy study a direct reason for why it is now approved, or did the approval come before? And if so, like how did the approval happen?
So I'm not a regulatory affairs
Okay.
specialist. So it is quite complex to get approval for devices, and it's different in Europe and in the US. Like in Europe, we have CE mark. In the US, you have FDA approval. So in Europe, we didn't have a specific study in pregnancy, but there was sufficient accuracy data in other individuals that we got approval. Now, these are delicate conversations, and there's a bunch of conversations that happen with the FDA to understand what data is required.
Okay. What was your involvement in this study?
Well, in this specific study, this study was an accuracy study done in the US, so I was not personally involved.
Okay.
In Europe, we support mostly investigator-initiated studies. For example, the automated insulin delivery study that was also presented at EASD by Professor Helen Murphy. So we tend to do more post-market studies out here, so with devices that are approved or already in the market, to show the clinical benefit rather than the accuracy. So it's two different categories, really.
Okay, and let's get into that automated insulin delivery study. First, before we talk about that, up until recently, what has been the usage of AIDs, automated systems, for pregnancy? How long have they been used for a while, or is this kind of new?
It is kind of new. There was some pumps were approved for use in pregnancy, but really closed loop was not really used. And if it was used, it was used basically off label. I believe there's other brands that and other companies that have approval for pregnancy, at least for the pump. But this study conducted by Professor Helen Murphy in the UK, this was the first large randomized controlled trials looking at assessing the benefit of hybrid closed loop in pregnancy over standard of care, which out here in England is CGM standalone. So this was a randomized controlled trial, really solid design, and really proved that using hybrid closed loop in pregnancy is beneficial in terms of increasing time in range and with some signal in improvement in neonatal outcomes. The study was conducted with the Dexcom G6, the Dana pump, Dana RS, and the Cambridge APS FX closed loop algorithm, which is approved for use in pregnancy out here. So the approval came before the trial in that case for the algorithm.
Okay, and does the approval, you're using a lot of pumps, or a lot of pumps were used, the pump and the algorithm are being used from Europe. Does this study also include the US?
No, this was just
Okay.
a European study.
Okay.
Now, will the results be generalizable to the US? So can you use this evidence in the future to support the use or the reimbursement, for example, of hybrid closed loop in the US? Probably yes. There are differences, of course, in the healthcare systems and in how women are treated. The algorithms will have FDA approval. You will be able to inform, for example, women about this study and about how women in England were able to get better results with this system, with its G6, the Dana pump, and the Cambridge algorithm. But the study itself was conducted just in the UK.
Yeah, I mean, this just seems kind of groundbreaking to me that all of this stuff is coming out now. It also just feels like it's taken way too long, and I feel like I've heard throughout my years that just women's health in general, there's not as much
That's
information
true.
and money put into it. And I'm glad we're here. I know there's probably a long way to go, but it's great that this,
Absolutely.
finally happened.
A lot is being done to make sure that women are equally represented in research as men. And I would go even further, if I'm honest, because yes, including women is one thing, including pregnant women is another thing. If we start
Right.
considering other factors like social background, ethnicity, different women who live in rural areas versus big cities, there's a huge equity issue here. So we are getting much better now at including people from different backgrounds to make sure that the data we produce with our studies are generalizable to a broader population. We need to make sure that the data that is generated can benefit everybody. And unfortunately, so far, some populations have been privileged in that there is a lot more evidence generated with patients that look like them and we
Yeah.
need to expand this. We're getting much better now, and more trials are reporting a good breakdown of ethnicity, social background, education, all factors that we think might influence outcomes. Um,
Yeah.
we're not there yet, but we're getting better.
Yeah. Yeah, that's very well said. I was reading this study a little bit, and the study, the problem that they were focused on was that, quote, most pregnant persons don't have glucose in the pregnancy specific glucose target range. Do you know what that percentage is like, or that time and range overall, kind of prior to these closed loop systems looked like?
So it's this is a tricky question because we are in a phase of transition. So to me, there is a pre-CGM era
Hmm.
where I would argue that there was no woman who had 70% time in range, but we can't know because we couldn't even measure that. It wasn't even a thing, time in
Yeah.
range. Now, more and more, CGM is becoming the standard of care. For example, there was an audit just came out, the results just came out, an audit from English data where women who were pregnant were off with type 1 were offered a CGM. And that shows that we are getting closer to target. So in theory, we would like women to get at least 70% time in tight target. Tight target meaning it's a much stricter target than what you're used. For example, your target is 70 to 180. For women who are pregnant, we're talking about 64, 65 to 140. So they need to have 70% of their time in there. Now,
Wow.
with the AiDAPT trial, what they were able to show is that with hybrid closed loop, that target is reachable. There are women who are able to get there. So it's you need technology because managing everything on your own, it's hard, as you know. Every day is different from the next. There are so many things that happen, and imagine having to manage all of what you normally do while also having a little baby inside you that is sucking up your glucose and producing all hormones and creating a hormonal mess. So technology is crucial. It helps,
Mhm.
and I had the privilege and the honor to talk with a couple study participants of the AiDAPT trials, and the way they talk about how technology has transformed the way they lived their pregnancies is incredible. It makes everything worth it, all the work we do, because they said, I was able to focus on being pregnant rather than managing my diabetes. I could delegate some of that work to this wonderful thing that is hybrid closed loop, and I could actually enjoy this wonderful time in my life that is my pregnancy. So, absolutely phenomenal to hear. So, getting there.
Yeah, that's really sweet to hear, and I'm really happy to hear that, that it really transformed these people's lives. I mean, it's helped me in so many ways. It's helped listeners in so many ways. It's a full-time job managing
Yep.
a pancreas, and
Yeah.
adding
Being.
multiple
Yeah.
levels of, I have work, and then, oh, I'm pregnant. I'm managing another life inside me. Like,
Yeah. Exactly.
that's a
Exactly.
lot. That's a
There's
lot of
never a good
layers.
there's never a good time for a diagnosis. It's always a shock. It's always complex, and it can be heartbreaking. I mean, you've gone through it yourself, but now
Yeah.
at least we can say, okay, let's relax. There are things we can do. There are things that will help you in this journey, and you can manage. You can, and it's so good to be able to delegate some of that to machines that are intelligent in a way.
Yeah. Were there specific numbers that came out regarding time and range, and were those compared? Was there a control group in this study
Yeah,
also?
absolutely. Absolutely. This was a randomized controlled trial.
Okay.
Maybe I should have said it from the start. So there were 124 women that were randomized to either receiving CGM standalone or CGM with a pump and the Cambridge APS-FX. And they received their intervention at about 10 weeks, so as soon as they knew they were pregnant. Now, at the end of the trial, the difference in time and range between the two groups was of 10 percentage points, which is enormous. It's really, really big. So it means that women who were in closed loop spent on average 10.5% more in range with respect to women on standalone.
Wow.
But mind you, we're talking about time in tight targets, so 63 to 140 milligram per deciliter. Women in standard of care, so on CGM standalone, had 55.6% time in range, which is not bad. It's much better than what they were used to with this MBG. And with closed loop, they got to 68.2% time in tight target.
Yeah,
And at
in a tight
baseline, tight target, yes, which is quite phenomenal. The interesting thing to me about this trial, and that's why it's so exciting, is that the increasing time in range from baseline, at baseline, all women were about 47, 44% time in range, time in tight target. The increase was immediate. From week 8 to 12, so from baseline, you see that the closed loop immediately allows you to have 65+% time in range. And this is notoriously difficult to achieve. In all the pregnancy studies, you see that women really struggle in the first couple trimesters. Then they tend to get better, at least for HbA1c, for example. This study shows an immediate effect of hybrid closed loop, immediate improvement in time in range. This is phenomenal, and this will really revolutionize how women with type 1 live their pregnancies. And it's phenomenal news for women with type 1.
Yeah, that's great. Do you think that there could be or should be an algorithm that's specifically for people who are pregnant?
Absolutely. So the Cambridge APS-FX is the algorithm that is approved for everybody. So it's the same algorithm for healthy men in their 20s and pregnant women, right? So, and even with this, the fact that it has a very, you can set your target quite low, which is crucial in pregnancy, allow women to have these great results. Now, I'm aware of at least one trial where they are assessing an algorithm that it was developed specifically for women who are pregnant. So looking forward to seeing the results of that. I think it will be fantastic to be able to have something that is specific and tailored for this time of life.
Wow, that's cool. I want to learn more about that for sure. I'm gonna
As soon as the
ask you
data is
about that
out.
later. Yeah, yeah. Um, you mentioned this earlier that there's a lot more work to do, and we are doing more work on research. Do you know of any specific studies that are going on now in this area?
There's a few studies. So, of course, now we know that CGM can benefit women with type 1 who are pregnant. But of course, we talked about type 2 diabetes and we talked about gestational diabetes. So there are a couple of studies that are currently running to show that CGM, with the hope to show that CGM can benefit women with gestational diabetes. There's a couple studies in Europe, large randomized controlled trials. And of course, we need to consider also type 2 because, women fall pregnant a bit later in life now. People are getting a bit heavier, so there's an obesity problem. People are getting diagnosed with type 2 diabetes earlier. And these pregnancies are quite complicated. So if you have a condition of type 2, so you tend to have high insulin resistance and complicated metabolic state, adding to that the insulin resistance from a pregnancy makes the whole management of glucose quite complex for type 2 women. Plus the fact that they can be overweight, it can lead to complications. So it's a population that is, again, at risk. We don't have a lot of evidence yet for that. So I'm hopeful that there will be more studies in pregnancy complicated by type 2. In the meantime, we have a few studies running in gestational diabetes.
Are there people who kind of dip into type 2 as they're pregnant and then come out of it? Is it possible to find a distinction between gestational diabetes and type 2? Does that make sense?
So yeah, it does make sense. So sometimes a woman is first diagnosed with type 2 diabetes during pregnancy. In truth, you only really know if it's a type 2, if the condition doesn't resolve um, after birth. But if glucose values are really, really out of control, sometimes those patients are treated as if they have are as having type 2 rather than gestational. So it can be that sometimes you have a pregnancy and you just discover at that point that you have indeed type 2 diabetes. Also, with gestational diabetes, as we said earlier, there was a large study called the HAPO study where they associated hyperglycemia with complications, and also they did a follow-up study showing that have gestational diabetes, you're more likely to have glucose intolerance down the road, you're more likely to develop type 2 diabetes, and not only that, the offspring of gestational diabetes mom are more likely to have glucose intolerance or glucose tolerance impairments when they're adolescents. So it's a tricky condition that affects two individuals, not only in the moment, but really down the line.
Yeah, and how do you think diabetes technology can become better for those who are pregnant? We kind of touched on the algorithm a bit. Is there anything else?
Yeah, I think we can do a lot to improve the visualization of the data, making the data more suited for example, a week-to-week view rather than having 3 months, giving insights on that are pregnancy specific, on what your data means, helping keeping that tight target, changing the target on your app, but really helping women interpret the data. And again, I think if you have type 1 and you're pregnant, you should be offered a hybrid closed loop at this point, because the evidence is there and it's so staggering, so much that the outcomes are so much better.
Yeah, I think the more people on automated systems, the better. And the fact that all this information has come out and showing
And
it's
again,
proven.
hybrid closed loops are there. We have approved systems now. They're not for everybody. Some people may prefer a pen, and that's absolutely fine. If somebody manages their glucose fine with a pen, they should be allowed to do it. In some situations, high risk patients where that extra help might be needed, I think it's only fair to offer that option to patients. Patients must have choice in the end, because you live with your diabetes, you know your diabetes, you know what works for you, and there's no one size fits all.
Yeah, and I mean, pending insurance things with, at least in the US, I would hope that people who are pregnant have the option at least to use a pump with closed loop during the pregnancy. And then if they want to go back to MDI, multiple daily injections, after that, they could do so. And
Yep.
that would be something nice to see too.
For the moment, I believe you have to wait a little bit longer in the US because
Yeah.
of the regulatory limitations. For the moment,
Yeah.
the algorithm is approved in Europe.
Okay.
So hang in there. It will come. It will get approval in the US as well, and hopefully
Okay.
you will be able to have choice as well.
Yeah. And for my European listeners, what pumps are currently available to them to use closed loop?
So if we're talking about the AiDAPT trial and the
Yeah.
results, or and for what device these results are applicable. So the study was conducted with the Dana RS pump, the Dexcom G6 and the Cambridge APS-FX. Now, the algorithm, the Cambridge APS-FX, is approved for use in pregnancy. So the algorithm is available on the IPSO pump, for example, and it's connected with the Dexcom G6 for the moment. It's connected with the Libre 3. It will be soon connected with the G7. I don't have a timeline for that for the moment. It's coming soon. But the algorithm is the Cambridge APS-FX with the IPSO pump and the Dana pump for the moment.
I plan to have someone come on the show soon to talk about their experience with the IPSO Med and the CAM APS.
Yes,
CAM
exactly.
Yeah, I don't fully know a ton.
Yeah, the Cambridge APS-FX is the algorithm that was developed by Professor Roman Hovorka at the University of Cambridge. It's the work of a lifetime, I would say. So I remember we were doing trials in 2009 and with the old platforms. So he has dedicated his life to developing algorithms for people with diabetes. So it's a great testament of his work.
Yeah, that's fantastic. Before we go, is there anything that we didn't cover that you want to tell us about?
No, I'm just so happy for women with diabetes who now have options, and there's a lot of hope, a lot of excitement, and opportunities to have healthy pregnancies where they can be, women first and patients next.
Yeah, definitely. Yeah, Steffi, thank you so much for coming on the show. This was just such a wonderful interview and conversation, and I'm happy to see that we're moving forward and pregnancy can become a less intimidating thing for people who either have type 1, type 2, or I guess are prone to gestational diabetes. So
absolutely. Thank you for having me.
Of course. Thanks for listening to today's podcast. On next week's episode, I'm speaking with Melinda Strauss. She is a type 1 who has 2 children. We're getting into her pregnancy experience at a time when CGM technology didn't exist. It's a great conversation, and I'm very excited for you to hear it. Once that's up, I'll throw the video in today's show notes of this episode. Also, down there's also a link for the T1D Exchange Registry. It supports the channel when you sign up, but not only that, and more importantly, it helps push diabetes research and treatment forward, and sometimes you even get compensated for those surveys. New episodes of this podcast release every Monday, wherever you listen, and on YouTube. There is a link to my YouTube channel and all my social media accounts in today's show notes. I'm Justin, and I'll see you next week.